Meningitis. Meningitis can occur because of bacteria, by virus, by fungus, by spiros, by parasites. It can occur with anything. Meningitis. Meningitis can occur with any organism, including TB. It can occur with anything. TB. It can also cause meningitis. Okay. Meningitis is simply inflammation of the menings. It's simply inflammation of the menings. Clear? Now this is clear. Okay. So for meningitis, what kind of edemas can you form? What are the kind of edemas you get in meningitis? You should know this. So you have many types of edemas that you get in meningitis. The first kind of edema you get is called a cytotoxic edema. Cytotoxic edema. Cytotoxic edema. Cytotoxic edema is what is happening in cytotoxic edema in human? Sorry? Sorry, go ahead. Why? Why do you get cytotoxic edema? So what's happening is there is bacteria that is going inside. This bacteria has started releasing those three important things: TNF alpha, interleukin beta, interleukin 1 alpha, interleukin 6, matrix metalloproteinase. All these are getting released. So what is it releasing? The bacteria is getting inside the body. It is releasing interleukin 6, interleukin 1 alpha, TNF alpha, interleukin 1 beta. Interleukin 1 beta, matrix metalloproteinase. These are all cytokines and products that are getting released as a result of inflammation. Now what is this causing? This is causing a shutdown of the mitochondria. This is causing shutdown of the mitochondria. All of these proteins are going and causing shutdown of the mitochondria. The mitochondria is very essential when it comes to the sodium potassium ATPase pump. Very important. So if there is no mitochondria, there is no ATP. If there is no ATP, there is no sodium potassium pump. The function of the sodium potassium ATPase pump is to pump out sodium and take in potassium. This is their function. The function is pumping out sodium and taking in potassium. Now because of the fact that this pump is not working, sodium accumulates inside. With sodium, what moves inside? Water. That's the usual thing. So the cells swell up. It was small, they swell up. And that's why if I develop cytotoxic edema. Cytotoxic edema. Clear on this? Clear on this? So TNF alpha, interleukin beta, interleukins, they get released, matrix metalloproteinase because of bacteria come in. They get released, they cause the sodium potassium ATPase pump to stop working or reduce working because mitochondria are damaged here. Since mitochondria are damaged, sodium remains in the cell, potassium moves out of the cell. Since sodium remains in the cell, water gets into the cell and causes edema of the cells. That is cytotoxic edema. Clear? Then the other edema that you get in these cases is vasogenic. What is vasogenic edema? Any idea what is vasogenic edema? So what happens vasogenic edema? What is vasogenic edema?
Interstitial space. Edema gets into the interstitial space. We discuss this in like strokes and all. You also get that.
So what happens is in vasogenic edema, your entire blood-brain barrier is actually very, very intact. What is the meaning of blood-brain barrier? What is blood-brain barrier? Where is the blood-brain barrier? It's here. Where is it? Is there a blood? Where is it? Barrier बोलेगा तो barrier ही बोलते हैं. क्या बोलते हैं इसे barrier? So understand this now. Okay, blood-brain barrier is the vessel and the neuron. The vessel and the neuron. Okay, this is the barrier. That means you have endothelium and you have the end plates of the astrocytes. Okay, that's the blood-brain barrier. It's called end foot processes of the astrocytes. And you have endothelium. This is the blood-brain barrier. Now, what has happened because of this extreme amount of inflammation that has occurred, all these macrophages and all of these things, this endothelium is destroyed, and the end foot processes also get splayed out, get opened up, and that causes internal proteins to come outside. The proteins that are inside, it comes outside, and that's why when you do a CSF, you're getting protein. You're getting the point? This comes outside, and this is vasogenic edema. Clear on vasogenic edema? Again I'll repeat. The blood-brain barrier is the barrier from the blood and the CSF. Anywhere the full brain is full of blood, all the vessels are there in the brain. The brain vessels are separated by the CSF and the cells by the endothelium, and the end foot processes of the astrocytes. Clear? And that is your blood-brain barrier. So when you have an inflammatory tendency, when you have an infection, what is happening? These cells are getting spoiled. Endothelium is getting destroyed. When this endothelium are getting destroyed, the end foot process is also having a problem. They get splayed out. They open up those spaces. It becomes leaky. The blood-brain barrier becomes leaky. When the blood-brain barrier becomes leaky, that is when you have the proteins and plasma cells to actually move out into the interstitium. Okay, causing vasogenic edema. That's why it's called vasogenic. That's why it's called vasogenic. Clear? Clear? Clear till now? Vasogenic edema. Clear? Then you have vascular edema. Now what is vascular edema? I won't call it vascular. What do I call it? If this is cytotoxic, this is vasogenic. Let me call it something else. Interstitial edema. Now let's call it interstitial. What is interstitial edema? This is different from vasogenic edema. Let me explain to you what this is. It's called interstitial edema. What is this interstitial edema? Now you have the choroid plexus that is passing the CSF into the ventricle. From the ventricle, it is going from various places and then getting absorbed from the subarachnoid spaces into the other part of the body through all those astrocyte processes and all. Correct? Now, because of this high amount of inflammation, exudates are forming. The exudates are actually blocking the absorption back. Since it's blocking the absorption back, the ventricles are getting filled up. So the ventricles are getting filled up. The ventricles are now getting the CSF to move out. Getting the CSF to move out from the ventricles on its own by pressure. That's called as interstitial edema. Clear? That's called as interstitial edema. Clear? Nahi samjha. Now, usually you have the choroid plexus, na? The choroid plexus that is passing CSF, that is producing CSF by ultrafiltration, by active processes. It is creating CSF, choroid plexus. Usually what happens is when we say 150 ml per is there in your body, 150 ml is not stationary there. It is keeping on coming in, going out, coming in, going out. It keeps on rotating to an extent that totally on an average day 567 ml is formed on an average day. Okay. Now what happens over there is that this is coming from here, getting into this, coming out from various parts, going from your third ventricle, aqueduct. So okay. Once it goes back into the subarachnoid spaces. From the subarachnoid spaces, it is further absorbed back, and then again comes back. Clear on this? From the it is absorbed back, and further it comes back. Now that absorption over here is not taking place. Since that absorption is not taking place, what is going to happen? This is going to fill up here, This is only space left. This is filling. The ventricle becomes bigger and bigger. When the ventricle becomes bigger and bigger, because of the pressure inside, CSF leaks outside. So on an MRI, you will see ventricle and white coming out here and there. You see on an MRI. That's what you see. On an MRI, you will see white coming out from here and there. It is a lecture. Just I am on a lecture. Okay. CSF coming out. Clear on this? Clear, everybody?
Yeah, it's edema.
It's edema. So this is. Now you are clear on this?
Yes,
but what you said initially was this is not obstructive. This is not obstructive edema.
Yeah.
Because it is still flowing. It is still going down. So usually in meningitis or TB meningitis, you don't get obstructive hydrocephalus. It's not obstruction. It is not absorbing here. Obstruction is when you have a physical block. You understand? So when very rarely you can get obstruction. That is when you have TB meningitis with a large amount of basal exudates, and this large amount of basal exudates are now holding on to that aqueduct of Sylvius. Isn't it? The very thin part, third ventricle, aqueduct of Sylvius आएगा ना? Third ventricle and then aqueduct of Sylvius आता है. वो aqueduct of Sylvius को जाके ना वो इतना झगड़ लेते हैं वो exudates that now it becomes obstructive hydrocephalus. Very rarely. Very rarely. Usually it's communicating hydrocephalus. जैसे hydrocephalus है, लेकिन कोई obstruction नहीं है, physical obstruction नहीं है. Absorption related problems है. समझ में आ रहा है? Clear? It's a big difference. Okay, obstructive hydrocephalus. So the other reason why you can have edema is because of obstructive hydrocephalus. Pressure in the brain can increase because of obstructive hydrocephalus. Clear on this? So we've had 4 causes when a person can get raised ICP, or for that matter, edema inside. The basic is ICP. On a cytotoxic, if now understood how cytotoxic edema comes in, we've understood how vasogenic edema comes in. you've understood how interstitial edema happens, and also obstructive. That's why you should know this. You should know this because the treatment is directed towards that. What kind of edema are you coming up with? You know, that's the thinking in your mind. That's the thing in your mind. So, in order to prevent cytotoxic or vasogenic edema, what will I have to do? What is happening? Again go back. Bacteria coming inside, bacteria causing a marked inflammatory process where IL-6, interleukin, TNF-alpha, matrix metalloproteinase is coming, which is causing cells to swell up because sodium potassium ATPase pump is going down, which is causing the vasogenic edema because of the fact that it's causing the endothelium to get damaged. So what will be the treatment here? Reduce the inflammation. How do you reduce the inflammation? Two things. First, kill the bacteria.
Antibiotics.
Kill the bacteria. And second, prevent the inflammation by giving steroids. Sound mein aa raha hai? Clear on this? That's why you should know this. Why am I giving the steroid here? Okay, the logical reason to give the steroid is, one of the reasons, and why do you want to give the steroid prior to the antibiotic? Usually you want to give the steroid prior to the antibiotic. When do you want to give the steroid? Usually prior to the antibiotic or within an hour of the antibiotic. Within an hour. Why do you want to do that? Any idea?
Excessive bacteria की death से भी
Correct. The answer is this. The answer is, what happens is, once you have a bacteria inside, and I told you that the bacteria just multiplying like mad inside the CSF, because there is no macrophage, there is no WBC, there is nothing there. So just multiplying in the CSF compartment. You give an antibiotic, thak karke the bacteria will die. When the bacteria are dying, it is going to release its products. When it releases its products, it's going to have more inflammation. You understand? Cell lysis of the bacteria will cause more products. For example, the commonest organism you see is Streptococcus pneumonia. Streptococcus pneumonia has got a toxin inside its called as pneumolysine. Pneumolysine. The pneumolysine will come out, cause more inflammation. I want to prevent that inflammation, so I give the steroid. And that is why I give the steroid prior to the antibiotic, or within 10 minutes of the antibiotic, or within an hour of the antibiotic. So the classical course is, patient has come in, you do an LP, give steroid, give antibiotic. Clear? Clear till now? Classical course. Now how much of the antibiotic in such cases? So the usual dose for antibiotic in such cases is 10 milligrams 4 times in a day. This is the usual dose. This is different from the dose that you had for TB. In TB, the dose was 0.4 milligram per kilogram, which means 24 usually, which means 24 to 28. No, 6 4s are 24. 60 kilo in dose will be 24. Correct? 6 in TB. Correct? On this, it's be 24. So it may be 8 3 times in a day, or 6 4 times in a day. You know, for TB, what it will be? 6 4 times in a day. Whereas here it is 10 4 times in a day. The difference in the steroid use in TB is, you're giving the steroid use for a longer period of time. You're giving it for 8 weeks, 6 to 8 weeks. In bacterial meningitis, you're giving it for 4 days, only 4 days. Why is that so? Can you tell me why? In TB you have 6 weeks and 8 weeks, and here you have only 4 days. Any idea? Any idea?
Because in TB you have that intensive phase.
But you 6 to 8 weeks you're giving. Why you're in 2 to 4 days you're stopping? So as I told you,
Mortality benefit is not there.
no, that's not the answer. The answer is, TB evolves. TB evolves into granuloma. TB evolves into other things. You understand vasculitis? It is evolving. TB slowly and steadily. TB is not a very different. Why these other things are not forming granulomas? Why that TB is forming granuloma? Why TB is going to vasculitis? Why others are not going to vasculitis as much? Because TB has got a very different physiology. What is different in physiology? What do you think is different in TB versus bacteria?
The weight.
Type 4 hypersensitivity.
No?
Weight's very
No?
different.
What is the difference? Huh?
And
TB is
Cell
purely
division.
intracellular. TB is purely intracellular. What happens is, the moment a TB bacilli gets into the CSF, there is one organism that comes and recognizes, that's the macrophage. The macrophage enters inside and it engulfs the TB bacteria. Now, since the macrophage is engulfing the TB bacteria, usual mechanism जो हमारा है वो काम नहीं करता. You understand? Because it's become intracellular. Are you getting the point? It is protected now rather.
Yeah.
So it's very difficult. So what does the body need to do at this stage? It can't use its immunoglobulins and all. It needs the TH cells to come in. The TH1, thymus, the T helper cells to come in. So when the T helper cells come in, then only it will start working. And that is the reason that HIV patients, because the T helper cells are less, they get this TB. Because it's intracellular. You're getting the point? So when the T helper cells come, it's not an immediate process. It takes time. So धीरे काम करेगा. Unlike immunoglobulin coming in, the cell coming in, neutrophil and finishing it off, which happens in bacteria. You understand? So such a patient develops granuloma, develops long-standing basal exudates, vasculitis, other problems, abscess, I don't know what not they may create, because it's going to take time. That's why for TB you want to give it for 6 to 8 weeks. Whereas when it comes for bacteria, because it's neutrophil dominant, it's going to work without T cells. It's just going to work. It's just going to work that way. And you know that that area is actually sterile. The moment I give an antibiotic, ठक करके वो उसको जो खराब हो गया ठीक कर देगा उसको. Within 2 days, within 24 to 48 hours, the cells will be gone. Within 24 to 48 hours, the bacteria is gone. Are you getting the point? Since the bacteria is gone within 24 to 48 hours, I don't need to give the steroid for more than 4 days. Are you getting the point?
Then why do we continue antibiotic for longer than that then?
Yeah, so we have the after effects, we have some bacteria remaining. Okay. You still don't have cells inside.
Right.
There's a minimal. So that is why in 48 hours if the patient doesn't wake up and look at you, if he's altered mental status and 48 hours के बाद वो उठ के वो तुमसे बात नहीं कर रहा है, मतलब something is wrong.
Something else is.
Because ideally what should happen? You give the antibiotic, 2 दिन में ऐसा बैठ के will start talking to you, eat food and normal. That's how meningitis should behave. But if it's not happening that way, means you're missing out on something. That's why that is the indication of repeating the LP. You get the point? That is the indication of repeating the lumbar puncture because you've missed out something. So you missed out something. Maybe it was fungal, maybe it was TB, maybe it was a drug-resistant pneumococcal bacteria. It may be not the usual thing that you get on the CSF picture. Something is wrong. That's why you need to repeat. For example, that guy, why we repeated. Got the point? He didn't improve, he repeated. You get the point? समझ में आ रहा है? Clear on this? Clear till now? Of when the steroid goes inside? What was known was direct study actually long ago. Direct study actually looked at this steroid in kids, in very babies, and they found out that those kids who had streptococcal pneumonia, streptococcal pneumococcus causing bacterial meningitis, hearing loss reduced when they gave the dexamethasone. That is the actual evidence that the hearing loss that happened that came down, and that's why the steroid dose comes in. But logically speaking, we know this cascade. Logically speaking, we know this cascade is there, and that is the reason we want to give the steroid. Clear? 4 days में the HP axis does not set in any way. Up to 8 days, there is no problem. You can hardly stop it. Hard stop. You get the point? It's a hard stop. Getting the point? What I'm saying? Nothing happens to the HP axis. You don't need to steroid taper. It's not required. Nothing is happening to HP axis. 4 दिन के बाद DEXA switch is off, comes off the list. Unlike in TB where you have to go slow and steady. You getting the point? Clear? Slow and steady. 2 reasons for going slow and steady in TB. One reason being that you might set the HP axis, and the second reason being when you reduce the steroid, the TB bacteria are still working on T helper cells. They're not gone. They may come back. You understand? And they may again have a problem. You get the point? So you may have to, the steroid taper in TB is a little bit more tailored to the patient rather than a number. So it means तुम steroid taper किया, तुमने ठीक है patient और खराब हो रहा है, नया granuloma form हो गया. Means तुम्हारा steroid taper का मतलब नहीं है. समझ में आ रहा है? You have to go back to steroid, go back to an increased dose rather of steroid. You getting the point? So the steroid taper in TB meningitis is a more artistic procedure, a more understanding procedure, more clinical procedure. Whereas a steroid is not tapered at all in bacterial meningitis. And specifically, this works in Streptococcus pneumonia. This comes to the question, what is the usual bacteria that you see in TB, in meningitis? Very good. So you must have this in your mind. Okay, what you have. So what will be your common bacteria that you see in meningitis? Strep?
Pneumonia.
Now, Streptococcus pneumonia. What is pneumococcus? When I say strep pneumonia, pneumococcus. What is pneumococcus? It's the same thing.
Same thing. Yeah.
It's just the same thing. I mean, you should say it's the same thing. Why are you thinking like this? It's the same thing. Because I asked this question in one of the exams recently.
Coccus and pneumonia.
I asked him Staphylococcus pneumonia, and this now suspicion developed pneumococcus. Now what? So the candidate on the other side said, sir, so I will change the antibiotic. That's when I realized the guy doesn't know shit about Anand Narayan, never read it in their life. Many of us have not read Anand Narayan, but I'll tell you, I went back and read Anand Narayan after my critical care. I went back because it was such an important book. I mean, in my second MBBS, I just left it. I hardly read microbiology. Anand Narayan का book था ना?
It was very good actually.
ये कहाँ पढ़ेगा मैं Anand Narayan? वो कैसे भी pass हो गया exam. But then I went back after critical care and then I read Anand Narayan because it was so important book. It was such an important book. Okay, because it tells all this. It tells all of these things in that. Anyways, so Streptococcus pneumonia. Then
H
H influenza.
H influenza.
Neisseria
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 meningitis.
H influenza. Neisseria meningitis.
Listeria monocytosis.
Listeria
monocytosis.
monocytosis.
Then
Rarely E. coli.
Rarely E. coli. Which strain? It's called K strain.
Case.
It's called E. coli K strain. Then because E. coli has got multiple strains, so the K strain is the one. Okay, then you have the rest, no? You have the virus. Why are you forgetting virus? The whole virus list is there. BZV, HSV, enterovirus, CMV, that is immunocompromised, but CMV, toxoplasmosis, fungal meningitis, nocardiosis. So depending on what you're looking at, if it's a community acquired and non-immunocompromised status, you're looking at this. Okay, when looking at a immunocompromised status, you're looking at this. Also, Streptococcus is the commonest. Even immunocompromised or non-immunocompromised, the commonest organism is Streptococcus pneumonia. That's the commonest organism. Whether it's immunocompromised or non-immunocompromised. Okay, when you're in the age group of an adult, it's all these excepting Listeria. Once you go more than 60 years old, 55 years old, you become Listeria. You start Listeria coming in. Clear? When you are young, very very young neonates, then you are looking at E. coli and things like that. Nothing like. When you are looking at this list over here. Simple, not difficult at all. CMV, toxo, all that will come in this immunocompromised status. No cardiosis and all of these things. Okay. Now the question is, how do you diagnose this? So obviously you're sending gram stain, you're sending culture, you're sending, in that list, in the 4 tubes, the first thing I send is protein and glucose. So if it is bacterial meningitis, my glucose is going to be less than 40% of what is there in the blood. If it is bacterial meningitis, my proteins are going to be very high. It is going to be a range of thousands. Okay, if it's going to be bacterial meningitis. Anything less than that could be viral. Okay, anything less than that could be viral. If it's 500 or less than 500 grams, उससे कम रहेगा तो 0.5 से कम अगर कम रहा, it is viral. ठीक है? Then the cells. What are the cells usually? So cells are WBC. How much should that be?
Less than 5.
More than 5.
If it's
Normally,
What will be bacterial meningitis?
more than
thousands.
More than thousands.
More than thousands.
5,000, 6,000, 7,000, 10,000. Viral?
500.
Correct. It will be lower. Less than 1,000. Less than 500, 400. So that becomes viral. Similarly, fungal. What about lymphocytes? So initially, if you do it immediately, TB तुमको आज हुआ और आज ही तुमने किया, तो सब neutrophils मिलेगा. थोड़ी देर के बाद it becomes lymphocytes for viral or for TB. You're understanding? For viral or TB it becomes lymphocytes. So initial neutrophil predominance होता है. After some time it becomes lymphocyte predominance. ठीक है? Clear on this? Clear till now? About this differential we've understood? Now you come to the major rapid diagnostics. This is where you must understand what to do where. Okay, तुम TB meningitis अगर देख रहे हो तो तुमको rapid diagnostics करना बहुत ज़्यादा ज़रूरी है. Now you understand why you need rapid diagnostics. Why do you need it? Because you need to figure out what the hell this is. Is it what kind of bacteria? Is it TB? Is it fungus? Is it cytomegalovirus? What is it? I need to figure out what this is. Correct? Correct? So what is the rapid diagnosis I'm looking at? So you did allude to a few rapid diagnostics. The first thing that we have rapidly that is the gram stain. Gram stain, simple thing. So gram stain, you can see it. It's in minutes. Gram stain. Unfortunately, gram stain is seen well only when there is large amount of bacteria. If it's virus, if it's fungus, If it's all those things, very less you can see on the gram stain. AFB, very less. ठीक है, 20% दिखता है. ठीक है, समझ में आ रहा है? Clear on this? So gram stain is the first rapid diagnostic you can get, but unfortunately it's very poorly sensitive. Very poorly sensitive. दिखता ही नहीं कुछ भी gram stain में. ठीक है, gram stain. Then the other rapid diagnostic you can have. When I say rapid diagnostic means I'm trying to diagnose what is inside. I'm going to diagnose what is it. What is it? The rest were all phenotypics.
Yeah.
Glucose and protein और phenotype. तो कि ये हो सकता है, ये हो सकता है, ये हो सकता है. Diagnostic means find out क्या है. Which is the other one?
MTD culture.
ये smear हो गया.
Meningitis के लिए क्या भेजोगे तुम?
Gene expert, MTD.
Gene expert detects what?
Your gene.
Meningitis
Gene
के
expert
लिए
detects what? Gene expert detects what?
TB, your gene, not specifically.
So gene expert is the what?
TB only. TB mainly.
So see, listen. Now you understand this very carefully. Okay, I need to have rapid diagnostics here. I need to have it. I cannot have work without rapid diagnostics. Okay, and of course I'm going to send my culture.
culture
and
का time
sensitivity.
लगेगा. Yes.
But this is not rapid. This will take 72 hours
Hours, yeah.
before I get what is there, and another one more day before I get the sensitivity. So it is not rapid. No, in no way this is rapid. If I want to do my culture and send for culture, it will take me 2-3 days. You getting the point? So I may not require a lot of other medicines. I may change my medicines based on this. Clear? Huh? So it's a problem to actually start. You have to send the culture, but because why you have to send the culture? Because sensitivity तो पता करना हो गया है, तो भेजना ही है, confirmation करना ही है. Without culture you cannot do. Okay, but I still need a direction to understand where am I. Okay, what am I having? That's why I need another test. What is the other test?
NGS you can do.
NGS in 2 hours.
The most important one, the most important test that has been validated and that has been told to be done is the microarray, which is the biofire.
Biofire.
Okay, microarray testing. Okay, which is the biofire. Okay, so the rapid diagnostics has to be biofire CSF. This is the most validated of the tests. Most validated of the tests. Biofire CSF, which is a microfilm array. What is it called as? Microfilm. Company का नाम है Biofire. Company का नाम है Biofire. What is it? It is a microfilm array. Film array it's called. More film array it is called. So that is what is the Biofire. Biofire can come with many other companies. What we use presently is Biofire from this company. Biofire from the company Biofire. It's called Biofire. Biofire film array. It is basically testing is called film array. So unfortunately, how are these things done? No, these things are done by having a certain number of bacteria, not all. Okay. The CSF biofire contains what all? It contains Streptococcus pneumoniae, it contains H. influenza, it contains Neisseria meningitis, it has Listeria monocytogenes, it has got HSV, it has got VZV, and it has got enterovirus. I'll repeat this, what it has. So it's got Strep pneumoniae, that's why I put that first list in front of you, so that you understand which is the usual committee appointment with that. So क्या Strep pneumonia, H. influenza, Listeria, Neisseria,
then HSV,
VZV,
enterovirus.
enterovirus, and of course it has Streptococcus agalactiae. It has E. coli, but of a case strain only. What it is omitted? Everything else: Klebsiella, Pseudomonas, Acinetobacter, other HSVs, HHV, herpes, HHV. All that is omitted. No, all that is omitted. You're understanding? Everything else is omitted. So you are not. That's why you cannot rely on a biofilm array on its own. You need to have a culture that is done. You need to have the culture that is done. Because वो पूरा निकलता नहीं, वो common निकलता है. 90% of cases में जो मिलने वाला है वो निकलता है. You know, you get that test in how much time?
1 hour.
The time it reaches the lab, उसके 1 घंटे के बाद उनको टेस्ट मिलता है. That's why it's called rapid diagnostics. So many hospitals now have got the biofire in their hospital only, installed in their hospital. So like Leelavati would have there, HN hospital will have it there itself. You understand? They have it there also. We wanted to do it, but our volume is not that big to have it. You understand? So that's why when you do the CSF, don't say चलो भेज दो उसको biofire के लिए. You have to ensure that it has reached the lab and then call up the lab and figure out क्या आया है. दूसरा दिन मिलके क्या फायदा हमको? दूसरा दिन मिलके उसको कुछ फायदा ही नहीं है मेरे को. If I want to change anything, I can't change anything. Because imagine I am dealing with enterovirus. Why do I need to give ceftriaxone, vancomycin and the rest? and dexamethasone, that makes sense only. Are you getting the point? Are you getting the point? So I need that value to come in quickly, right? So the rapid diagnosis takes how much hours? Actually, 1 hour. So it has to go from hospital to lab, and lab process 1 hour. 1 hour later we should have the report. Okay? So this is about biofire or film array. Film array. So I still cannot omit my cultures. Okay. Now we talked about something called as NGS. Now NGS is not validated. NGS is not validated. NGS is not the drug, not the this. NGS में क्या होता है? There are two kinds of NGS. You said two kinds. One is M and the other is T. Okay, this is metagenomic NGS and this is targeted NGS. मतलब अगर मुझे पता है, मतलब इसका मतलब क्या है? इसका कैसेट में ना जो मेरे मन में है वो ही रहेगा. मेरे को मन में है कि शायद इसको HSV है या मेरे मन में है इसको STD साइटोमेगालोवायरस है, तो मैं टारगेटेड NGS करूंगा. I want to target it for this CMV or NGA for this or this something like that. You get the point? Whereas metagenomic means वो दुनिया भर का कचरा डाल देगा उसके अंदर, जो भी आएगा आ जाएगा. That is the problem with NGS. NGS में तुमको contamination आएगा, NGS में तुमको आलतू फालतू organisms आएगा. You need to understand whether this is the organism. But the फायदा इसमें एक और चीज होता है कि NGS जब भी करते हैं तो हमको एक और पेपर उसमें आता है which is resistance pattern. एक और पेपर आता है, एक पेपर आता है जिसमें ऑर्गेनिज्म का नाम रहता है और एक और पेपर आता है रेजिस्टेंस पैटर्न आता है. So you can then look at the resistance pattern because that may change the way you change the antibiotic. You understand? NGS समझ में आया? हाँ? NGS is not the drug, not the this I will use. If I have to do something, I will do Ramstein, culture, sensitivity of culture, and biofire film array. But if I really want to be as quickly as possible, and I think I am dealing out from the biofire spectrum, okay, then I will do an NGS. And then correlate that NGS, not take it as उसमें आ गया ये problem है, ऐसा नहीं. Correlate that NGS to what my CSF routine, what my patient was doing, what is my protein, glucose, correlate that. समझ में आ रहा है? NGS is not validated. ठीक है? NGS is not validated. Clear on this? But CSF biofire is validated. तो तुम लोग ऐसा सोचेगा कि ठीक है भाई, CSF biofire में इतना ऑर्गेनिज्म नहीं है. बायोफायर में सेप्सिस पैनल भी तो आता है. बायोफायर में आता है ना सेप्सिस पैनल, जिसमें 37 ऑर्गेनिजम्स आते हैं. सब ई कोलाई, क्लेप्सिला, सुडोमोना, दुनिया भर का नाटक आता है उसमें, राइट? तो मैं व्हाई नॉट आई डू बायोफायर सेप्सिस पैनल, क्योंकि उसमें है ना 37 ऑर्गेनिजम्स है, इसमें तो खाली 8-10 है. तो उसमें नहीं कर सकते हम लोग, क्योंकि इट्स नॉट वैलिडेटेड फॉर दैट. इट्स नॉट वैलिडेटेड फॉर सीएसएफ. It's only for blood. It's not for CSF. So you can't send a CSF sample and say blood panel कर दो. और ये बायोफायर सेप्सिस पैनल कर दो. नहीं कर सकता तुम सेप्सिस पैनल. समझ में आ रहा? It is validated only for CSF. This CSF panel, CSF biofire. Clear on this? हाँ, ये अगर है तो 100% है. इसमें अगर कुछ मिल गया तो 100% है. But can it be false positive, false negative? It can be false negative. Because अगर तुम्हारे पास वहां पर जिस सैंपल तुमने दिया है उसमें बैक्टीरिया या उसका डीएनए नहीं है तो नहीं दिखेगा उसको. So it can be false negative also. It doesn't mean that if my biofire is negative, patient does not have an infection. It doesn't mean that. It can still have these same things in a smaller amount. In your sample it does not come. You understand? That's why end result again comes to clinical, again comes to antibiotic culture and sensitivity. Culture sense. समझ में आ रहा है? That's why it goes back to clinical. You cannot omit clinical out of this. So that's why we go back. ये लग रहा है. Let me repeat. That's the thinking. समझ में आ रहा है? Clear? Now comes the treatment. Now when you have come with this is going to take, even rapid diagnostics in the best of the best centers will take 3-4 hours. In the best of the best centers, because तुम LP पहले करोगे, हाँ, उसके बाद LP का रिजल्ट जाएगा उधर, फिर वो बायोफायर रन करेगा, तुम्हारा हॉस्पिटल में भी रहेगा तो भी 2 घंटा जाएगा. LP को 1 घंटा, उसके बाद 1 घंटा, 2 घंटा तो जाने वाला है. उसके we cannot wait for antibiotics because वो golden hour बना रहे. ठीक है, 1 घंटे के अंदर अंदर हमको एंटीबायोटिक देना है, कुछ भी हो 1 घंटे के अंदर अंदर. So what is the empirical antibiotics I'll give? So I must think like this. How do I think? I'll think like this. Patient कहाँ से आ रहा है? Is the patient coming from the community? Is the patient immunocompromised? Is the patient underwent surgery recently? Is the patient has something inside his brain like a BP shunt? ऐसा मैं सोचूंगा. I'll think like this. 4 broad categories. Has the patient come from community without any other problem? I will think whether the patient is immunocompromised. I will think whether the patient has undergone some kind of surgery or hospital admission recently. And the fourth is, I will look for whether there is hardware inside the brain. BP shunt or Omaha reservoir or something like that. Because the entire picture will change based on that. If I have an Omaha reservoir or a BP shunt and things like that, I'm looking at Klebsiella, E. coli, Pseudomonas, Acinetobacter, because these are things that come from there. Okay, when I come to the community, I'm looking at this whole picture. Look at this picture. I mean, when there is Omaha reservoir, Staphylococcus also will come in because biofilm formation, all these things will come there. When I'm thinking of a patient who's been recently admitted and come back, then I look, did he have sepsis at that time? And what was the organism? You understand? Because if he had sepsis at that time and the organism was Klebsiella, I know this probably can be Klebsiella, I need to cover that. Okay? Clear on this? I need to cover that. When I'm having an immunocompromised patient, like a transplant patient coming in with all these situations, I'm looking at fungus, nocardia, all these things. You know, you're looking at all of these things, including everything else. So you see my antibiotic protocol completely changes depending on where from this patient is coming. Clear? So your history should be very clear. What is happening here? So for example, if you have a patient who is an IV drug abuser, an IV drug abuser will normally have staph. The staph has got infective endocarditis, got brain abscess or meningitis or whatever. Something like that. I think like that. So my history taking becomes alarmingly important, and that's why you should put them into these 4 buckets. Okay. Usually a common bucket will be this one. A common bucket will be community acquired. That's going to be a common bucket. It's very rarely you will have patients that are there in the hospital and developing meningitis. Very rarely you will have patients coming from outside with an Omaha reservoir, BP shunt and getting meningitis. Very rare hota hai wo, but you should know. You will have commonly, if you are working in a transplant center, you will see multiple meningitis coming in from patients who are immunocompromised. Okay, because they are all on transplant, all on medicines, transplant medicines. Clear on this? Clear? Am I clear till now? Clear?
Yes, sir.
So what will be my drug now? To cover all of these things, my basic drug remains ceftriaxone. Basic drug remains ceftriaxone. Ceftriaxone, first drug. The second drug I want to add is,
if more than 60, then ampicillin.
no, I'm in the adult age group. Drug, I'm talking antibiotic.
Vancomycin.
Vancomycin, you're right, but why?
Staph.
अगर मैंने किधर स्टाफ किधर लिखा है मैंने वैंकोमाइसिन, लेकिन वैंकोमाइसिन ने बोला बराबर, लेकिन क्यों? इसमें स्टाफ तो नहीं है ना, इसमें स्टाफ होता तो नहीं है बैंक. Vancomycin covers Staphylococcus aureus, MRSA, and things like that. But then we don't have it here. Then why staph? Which resistance?
Few patients are resistant.
So the answer is,
Coming in the
you are
hospital.
first trying to cover staph and H influenza. You are trying to cover staph and H influenza. Okay. So staph pneumonia has 50% of these may have drug-resistant staph pneumonia. Specifically, drug-resistant staph pneumonia. Staph pneumonia. Clear on this? Drug-resistant. When they are drug-resistant staph pneumonia, 50% of the cases are resistant to ceftriaxone. So you want to give vancomycin. Okay. But here there is a big issue. First of all, what you must understand over here is that whatever drug you are giving in the brain will not go more than 15% brain के अंदर, because blood brain barrier है. समझ में आ रहा है? blood brain barrier हमने just discuss किया blood brain barrier होता क्या है. ठीक है. blood brain barrier की वजह से वो brain के अंदर जाता ही नहीं है. 15% maximum जाता है. 15%. ठीक है. What is the dose of vancomycin that you give? Ceftriaxone you are giving how much? 2 grams. You see, the dose is not 1 gram. You are giving 2 grams. You are trying to increase the dose because the penetration to the brain is much lesser. Vancomycin कितना दे रहे हैं? Again 2 grams. Very high dose. It's not 1 gram BD. It's 2 grams. Why 2 grams? Understand this. When the brain is inflamed, that means blood-brain barrier is not okay. हमने डिस्कस किया ना, vascular edema हो रहा है. That means your drug should pass through. लेकिन हम क्या दे रहे हैं पेशेंट को?
Vancomycin is big molecule.
वापस मैं समझाता हूँ. We are having a patient who has cytotoxic as well as vasogenic edema. Correct? Vasogenic edema, cytotoxic edema के लिए हम क्या दे रहे हैं? Steroid. क्या दे रहे हैं? Steroid. Correct? Steroid से inflammation को क्या हो रहा है? Inflammation is coming down. अभी हम ड्रग दे रहे हैं, ऐसा सोचिए भाई inflammation है, ड्रग पेनिट्रेट कर जाएगा. लेकिन हम स्टेरॉइड देके वो इन्फ्लेमेशन कम कर रहे हैं. वी रिड्यूसिंग दैट इन्फ्लेमेशन. That's why what I need to do, increase my doses.
Okay.
You get the point? And that's why I am increasing my dose of vancomycin to 2 grams. You are getting the point? Why is there vancomycin first? Because you are looking at drug resistant streptococcus pneumonia. Okay. And why you want to increase the dose of vancomycin to 2 grams, giving potentially toxic dose? Because the penetration to the brain is less. On top of it, you are making it even more lesser by giving steroid. Clear on this? That's why the dose of vancomycin becomes 2 grams. Okay? Clear on this? Then which is the third drug I'll give? What am I not covering? I am not covering HSV, VZV and all these things, viruses. So the next drug I'll give is
Acyclovir.
Acyclovir. Okay, I'll start my acyclovir. Empirically just start 10 milligram per kilogram of acyclovir. One dose से कुछ नहीं होने वाला है. ठीक है, by that time my cell culture and all that will come, my cell gram stain and all that will come. तो उसमें मेरे को समझ में आएगा कि भाई ये वायरस है कि बैक्टीरिया है, क्योंकि अगर सेल मेरा 10,000 है तो ऑब्वियसली इट्स बैक्टीरियल, इट्स नॉट वायरल. आई कट ऑफ माय एसाइक्लोविर. समझ में आ रहा है? क्लियर है? ये सेल काउंट मेरा कम है, लिम्फोसाइट प्रेडोमिनेंस, आई विल स्टार्ट थिंकिंग वेदर दिस इज वायरल और टीबी. You get the point? I'll start thinking. That's why I go back quickly to get my CSF numbers. Clear on this? हाँ. तो ये हो गया ceftriaxone, दूसरा हो गया vancomycin. Okay. The third antibiotic I want to give, if by any chance, antibiotic is acyclovir. And the fourth one I'll give if the patient is more than 55 is ampicillin or listeria. Okay, for listeria. Very high doses, 2 grams 4 hourly. Again 2 grams 4 hourly. High doses. 2 grams 4 hourly. I mean 6 times in a day. Because I just explained to you, blood-brain barrier not going through. I want to give it, I need to give it in such a way that I give very high doses. Getting the point? So my doses are also high, my frequency is also high. Getting the point? So 2 grams 4 hourly. So the fifth drug that I told you before I give all of these things is steroid. So 5 drugs आग बंद करके भी तुम दोगे तो you will be right. Which are the 5 drugs? Ceftriaxone 2 grams, vancomycin 2 grams, acyclovir 500 milligrams for example, and ampicillin 2 grams and dexamethasone 10 milligrams. ठीक है? When you give these 5 drugs, empirically you have given the right treatment. Empirically. Okay, empirically given the right treatment. Nothing to think. कोई problem नहीं है. ये 10 दोगे, empirically you are doing the right thing. Okay, and then you go back to rapid diagnostics. So she did mention in TB what do you do? So in TB what do you do? Now this is a rapid diagnostic when it comes to bacterial. But if I'm suspecting TB, I have an immunocompromised patient, I've got a patient in the house that has got a close contact who's got TB. This person has got TB in the past. Now I have to rule in TB, CSF TB. Say this patient, a home patient has got TB in the past, pulmonary TB, or this patient has got vasculitic TB, or this patient has got TB from the family, someone in the family, past history of TB, or is an immunocompromised patient where I need to look at TB. What are the tests I'll do? Obviously, my CSF will give me a picture of lymphocytic predominance. It will give me cells that are low. It will give me proteins that are low, but not as low as bacterial. Bacterial में 10-20 मिलेगा. इसमें थोड़ा ज़्यादा 35-40 आएगा. ठीक है? The glucose that is. The protein will be high. You will see all of these things. But you need to rule in TB, and for that, the drug that I'm going, the kit that I'm going to use is the Gene Expert. It is called, the Gene Expert is called RF Ultra. Okay. Now this Gene Expert looks at only tuberculosis. The Gene Expert is looking only at tuberculosis. This particular for TB is called RF Ultra. MTB Gene Expert or RF Ultra. Now RF Ultra means what? It is giving you only TB का with the rifampicin resistance. With the rifampicin resistance. समझ में आ रहा है? I'm not going to use Gene Expert as I use for Expert Carba. The one that we use for Carba is called Expert Carba. Expert Carba. That's a different thing. Okay, it's a kit which contains Expert Carba, which looks at NDM, all those genes and all that we sent for. That's Expert Carba. But when I'm doing the same station for TB, it's called Gene Expert TB or RIF Ultra. Gene Expert Ultra, which will give you the RIF resistance also. Clear on this? Clear on what is I'm going to write? CSF Gene Expert RIF Ultra. This is what you're supposed to write. Clear? So that we know exactly what we're doing. Clear? Clear on this? Then I will also write AFB. CSF for AFB. But what I'm going to understand, AFB is positive only 1 in 5 times. AFB is positive. When I say AFB, what am I doing? Zeal-Nielsen staining. Zeal-Nielsen staining, then they put something else and they remove that stain and they see what is inside. Correct? Zeal-Nielsen staining. So AFB smear जब हम बोलते हैं, AFB smear उसकी possibility is only 1 in 5. 20%. It's only 1 in 5. Clear on this? When I say AFB, CSF, AFB. Are you getting the point? Huh? But she did mention something called modified AFB. Modified smear. What is that?
So, modified basically in that, I had mentioned it.
No. So you mentioned it wrong. That's why I asked you this question.
No,
So
it is-
concentration of
what is modified AFB? What does it detect?
like other atypical microbes.
Yeah, it is detecting other atypical ones like
Leopard.
nocardia.
Nocardia.
Like nocardia. This is exactly what the answer is.
0.4.
हाँ, अगर पेशेंट को हम सोच रहे हैं कि भाई इसको दूसरा कुछ है, हाँ, तो I have to ask for modified AFB smear. Modified AFB smear. What does that do? That the washing जो process होता है ना, उसको modify कर देते हैं हम लोग. First you stain, then you wash, right?
Alcohol concentration.
हाँ, correct. The alcohol concentration changes. The concentration changes is modified the washing process, and so the stain remains. So you are able to see the nocardia. So if you have a patient who's come for renal transplant and long term clinical, I want to rule out nocardia. I can't do this. No, my biofile is not going to give me that unless I do a targeted NGS and tell them look at nocardia, or do a metagenomic sequencing and tell me nocardia hai ki nahi. The other thing simply I can do is do a modified AFB also, or do a modified AFB also. The modified AFB might still give me whether there is nocardia. Clear on this? Clear? Huh? So for diagnosis of TB, what about the ADA? Not doesn't make any sense. ADA and all. It's not something that gets, after all, not TB. ADA can come even with just lymphocyte predominance. Maybe with other cancers it can come. AD can go up. Just if you have lymphocyte malignancy, it can go up. So a CSF AD does not tell you anything. It may just give you again just a subjective or a directional change. It's not going to tell you this is TB or not TB. For TB or not TB, you need to diagnose and demonstrate TB inside the CSF. Clear? Which can miss out. That's the reason that if you don't get it, do it again, do it again, do it again till you get it. If you strongly suspect that it is TB, do it again, do it again, do it again till you get it. You understand? Or look at other sites. Because you have a CSF, you feel it is not bacterial, it is not viral, it is not fungus, but I strongly suspect this is TB. Then I will do a bronchoscopy, I will do a PET scan, I will do this, that, and demonstrate TB somewhere. And then say that in Indian scenario, because this TB is there in that lung and this picture is not bacterial, viral or fungal, this should be TB. So let me start anti-AKT medicines. So you get to the point, because it's in India. You have to do it like that. You understand? That's how you diagnose TB meningitis. It's not easy to diagnose TB meningitis, and it's not easy for the patient also, because once you start TB meningitis, you're looking at 9 months, 11 months of treatment, patient pulling on water, water retention, sodium problems, SIDH, patient getting complications of TB meningitis, of which one of the most feared complications is vasculitic strokes. Vasculitic strokes. TB is known to form vasculitic strokes. And why does it form vasculitic strokes? Because the pathophysiology involves intracellular organisms. And since it's intracellular, it takes time to die. Since it takes time to die, धीरे वो vascular system को धीरे clot आजू-बाजू रह जाता है और vascular system vasculitis create करता है. Are you getting the point? So vasculitis is a known phenomenon that you see. Specifically, you have basal ganglia infarcts. Why would you have that? Because lenticulostriate arteries are end arteries. Lenticulostriate arteries which go through the basal ganglia are end arteries. So when you have vasculitis, the first vessel that will go down will be lenticulostriate arteries, and you will get vasculitis very quickly. Compared to bacterial meningitis, which is a hit and out. You hit bacterial meningitis, it's out, isn't it? The bacteria is out. Okay, you just hit it properly, it's out. Whereas in TB, it's not hit and out, because you're not dealing with that kind of cells. Here you're dealing with T helper cells coming in, then working hard, then taking out, so it's going to take time. That's why nutrition, exercise, ensuring everything is stable, all that comes very, very important when you have TB meningitis coming in. Otherwise, if you don't do all of these other things, your body doesn't have the capacity to take off the TB. You get the point? And you have to be certain that you are having no resistance pattern, because the entire thing changes if you have resistance pattern. Because if it was a 9-month therapy, it becomes 12, it becomes 16, it becomes 24 months. You understand? That's why the RIF ultra is important. RIF ultra. Also, you send the culture. The culture of TB takes 6 weeks. So you can't just do not culture. You still have to do the culture. Why you have to do the culture? Because you do the culture, you get the organism, and then you can do the resistance to everything else. RIF ultra is only giving you resistance to rifampicins. What if it's INH resistant? So to know that, I still need that culture, no? I need that culture. So if I am doing a CSF and I am strongly suspect TB meningitis, I still need to do CSF culture because for TB, because I need to figure out resistant T, which is very high prevalence in our country. Clear? Clear? Now let's take the example that this TB worsens and becomes a brain abscess. If the TB worsens and becomes a brain abscess, if it is less than 1.5 centimeters in size, I can still manage with medicines. Once it goes beyond 1.5 and develops mass lesion, like midline shift or things like that, nothing else but surgery. You understand? It needs an operation to removal of the abscess. There's no other way you can do it. What is the problem? The problem is when you're on steroid. Okay, when you're on steroid, what is going to happen is, you know, ideally what you want the abscess, I want to remove the whole abscess. पूरा पानी पानी रहेगा तो मैं क्या निकालेगा? अगर मेरे पास abscess है और वो brain के अंदर है और सब पानी पानी जैसा है, it's all liquefied. What am I going to remove? Nothing. To remove the abscess, it has to have a nice ring. It has a nice capsule. You understand? A nice capsule. So there has to be a nice capsule around it. If there's a nice capsule around it, I can scoop out that entire abscess out. I can remove the entire abscess out. He's got a nice capsule. Unfortunately, what is happening? We have put this patient on steroid. Since we have put the patient on steroid, this per se does not form. Okay? And that's the problem of giving steroids or not giving steroids. There's a problem that comes in giving steroids. That's why you should be very clear kya chal raha hai. And that is the reason that when you are actually doing meningitis, you should look for abscess. So if there is meningitis, अब तक कुछ form नहीं हुआ, abscess form नहीं हुआ है, ना vasculitis form है ना कुछ हुआ है. लेकिन समझ लो patient का FN, suddenly patient changes. Patient has a seizure, patient has focal neurological deficit, patient is not improving. ऐसा कुछ भी अगर हो गया, I will repeat my MRI to look for vasculitis. To look for, because if it's vasculitis, I'll require longer steroids, maybe a higher doses. I will want to look for conversion to tuberculoma. I will want to look for conversion to brain abscess. I want to look for brain abscess. Because if it's brain abscess and it is bigger than 3.5 or 1.5, I need to operate, I need to stop the steroid. Completely changes. So what kind of imaging I require? What kind of imaging I require? Whenever I am following up a patient, it's important for you. Which kind of imaging you require?
Contrast.
Okay, MRI? Contrast. The whole thing will be required. MRI contrast will be required, the whole thing. When I say the whole thing, T1, T2, diffusion related imaging, ADC, flare, and GRE. The whole sequencing is required. And contrast. The whole sequencing and contrast is required. Why do you require it? Why do you require it? You require it because, as I told you, what if it is hydrocephalus causing vasogenic edema? Hydrocephalus causing pressure edema, that is the kind of interstitial edema. So I need to see that on T1 because T1 में दिखता है वो ऐसा, T2 में दिखता है ऐसा, T2 में दिखता है ऐसा निकलते हुए, तो मेरे को T2 काम आएगा. Why do I need diffusion? Because vasculitis. If there is vasculitis, it will form a stroke. I cannot see it anywhere else. So diffusion I will require with the ADC because I have to confirm the diffusion. Because I have to confirm the diffusion, that's why I require diffusion ADC. The rest of these are responsible for hemorrhage. GRE is hemorrhage. What if there is hemorrhage? That vasculitic hemorrhage हो गया उसको. I can see it in GRE. Other thing, if I have an abscess and the abscess is showing bright on T2, capsule दिख रहा है तुमको और अंदर भी white है, तो ये हो गया ट्यूमर. ये हो गया ट्यूमर, मतलब वो ट्यूमर आ गया. ये टीबी नहीं है, ये ट्यूमर हो गया. लेकिन समझ लो ये अंदर ब्लैक है, लिक्विफाइड एब्सेस हो गया. यू अंडरस्टैंड? तो डिफ्यूजन मेथड में वो समझ में आता है मुझे कि भाई ये ट्यूमर है कि भाई ये एब्सेस है. बिकॉज कितना डिफरेंस हो गया दोनों में, कितना डिफरेंस हो गया. एक में तुम वेट करो, दूसरे में तुम निकालो. अगर टीबी तुम्हारा छोटा सा ट्यूमर है तुम छोड़ दोगे ना, कुछ नहीं करोगे, माफ करो कुछ नहीं करोगे. लेकिन आज उसको एब्सेस हो गया है, इसको एब्सेस अगर हो गया है, I have to take it out urgently. मतलब अब मेरे को अगले घंटे में निकालना है वो. Are you getting the point? So the entire thing changes. So that's why it's important for you to figure out whether the patient has got what is the progress. That's why you need the whole MRI contrast. You can't have just MRI. समझ में आ रहा है? Clear? So this is all about meningitis. Okay?